Good evening.
Thank you. Thank you, Rajiv. Thank you. And a very good evening to everyone. And my congratulations. My congratulations to you, Rajiv, as well as Sridhar and the IAP Neonatal chapter of, for really taking up this academic work with great enthusiasm and regularly organizing great symposiums like these ones. And of course, we are very fond of your book, Rajiv. So Dr. Peter has been introduced to you already by Sridhar, but I will just like to re-emphasize Peter has been, a kind of the boss of neonatal and pediatric ventilation. And I remember Peter visiting India in one of his several visits, including to my institute, PGI Chandigarh, for conducting several workshops on pediatric and neonatal mechanical ventilation. And I think, again, Peter's book is the most famous one about pediatric and neonatal ventilation. And I was fortunate to have contributed something to that book also. And as we see from his biodata, Peter has been very well accomplished researcher, academician, and is an editor of several important journals, including Pediatric Research. He has been an executive committee of the European Society of Pediatric and Neonatal Intensive Care Medicine and have been its past president. In 2021, he was recognized for his lifetime achievement with Denis de Victor Award from the European Society of Pediatric and Neonatal Intensive Care. And Peter is going to tell us about the most fundamental modality to treat ARDS, because unless we do this well, all other modalities are not going to work. So over to you, Peter, for his talk on optimizing conventional ventilation and recruiting the lung. Peter, all over to you.
Thank you, Dr. Praveen. So I just share my screen. Hope it looks fine.
Yeah, it's all visible.
That's today's situation in Geneva. Beautiful weather, sunshine in the afternoon. So I was asked to talk about optimizing mechanical ventilation in parts, including lung recruitment concepts. I have no conflict of interest to declare in relation to this presentation. So what are the unknowns in pediatric mechanical ventilation? Some year ago, I did a paper about this on invitation of intensive care medicine, and we sorted out that several things are not so clear as they seem to be in the adult world, or perhaps in the neonatal world. So what are the lung protective strategies? Small tidal volume ventilation and or pressure limitation. So is it correct to use tidal per kilogram, pressure limitation, limiting discharging pressure as a concept? And the other important concept is positive and expiratory pressures and lung recruitment strategies. So what about PEEP? What about recruitment concepts? So small tidal volume and higher PEEP. Everybody is defending this nowadays, as nicely summarized in this graphic by Martin Tobin, where he showed just when you use large tidal with low PEEP, as said before, you run the risk of atelectasis or overdistension stretch injury. So common concepts nowadays are optimized mechanical ventilation. That's what we all say. So we say use tidal was 5 to 8 mil per kilogram, use a limit plateau pressure below 28, and use higher PEEP. And then the big question about recruitment. I come back on the small tidal volume ventilation ARDS network trial, 6 versus 12 meter per kilo. Just to remind you that there was also in the two groups a big difference in inspiratory pressures or the peak pressures or the plateau pressures, not only the 6 mil per kilo that perform better. So you could say it's perhaps could be the pressures. And there was also the effect relatively small, because only 1 out of 14 patients had a benefit when 6 mil per kilo were used instead of 12 mil per kilogram. But what about 5 to 6 mil per kilogram in a pediatric population? There is Martin Kneiber's group, is the Jager, who could show by analyzing all the pediatric published data at this time, most of them retrospective studies, that there is no relationship between tidal volume mortality in children. As you can see, for different subgroups, 7 versus 10, below 7 versus 12, below 8 versus above 10, below 8 above 12 ml per kilo. No difference in outcome between the two strategies. Furthermore, and I just take this paper, there are other ones out, but just a paper from Sam and Erickson, who showed an inverse relationship between tidal volume ranges, so median tidal volumes, and outcome. So the higher the tidal volume, the better the outcome, as you can see here, with a OR ratio below 0.8. Whereas it could show that in-spirit pressures were directly related to outcome, so higher in-spirit pressures, worse outcome, as the OR ratio shows with a value above 1. So we could interpret this that the pre-existing degree of sickness relates to mortality too, as I tried to show in my keynote lecture as well. So in patients with less compliant lungs, high pressure resulted in small tidal volumes. This is interpretation what you observe here. So the patient that had 31, so the pressure limits, high pressure limits, was the one that actually ended up with small tidal volumes because the physicians did not allow for higher plateau pressure. So there were very sick patients, high pressures, low tidal volumes, versus less sick patients had larger tidal and did reach this only low pressures. Then means that we have in the lung protective ventilation, we have small evidence about the importance of a specific tidal volume as being protective, and we have even observed this inverse relationship in some studies. It was another one from Los Angeles as well. So let's go back and think about the basic pathophysiology of hypoxia respiratory. So it's restrictive lung disease. Restrictive means that we have a reduced FRC, so this function is a capacity. Patients that have a restrictive lung disease, they reduce the tidal volumes spontaneously and increase the rate. That's what we do. If we get an infection and pneumonia like this, we get tachypnea and reduce our tidal volumes. As a physiologic concept behind and response, we will have an intrapulmonary shunt, is resulting in hypoxemia and an increase in alveolar dead space, resulting in hypercapnia. And this describes the hallmark symptoms of ARDS, of restrictive lung disease of various origin. And this brings us back to the physiology, the baby lung, as I mentioned this before. So in restrictive lung disease, in inflammatory restrictive lung disease, the ARDS lung is small. So this was coined, this term, by the adults, where they looked into ARDS patients. They measured the areable remaining tidal volume in these lungs, and it was correlating to the age or the size of a lung of a 5 to 6 year old boy child with a normal lung. And this, for an adult, is the baby. So it's the small lung in the big body. And this was correlating, this residual inflated lung volume was directly correlating to the compliance measured in these patients. So the compliance is an indirect measure of this baby lung compound, so the percentage of the expected normal lung volume. And this brought us early on already the concept that the ARDS lung is rather small than stiff, so our tidal volume per body weight ratio does not make big sense because it does not take into account the severity or the expression of lung disease in terms of reduced residual inflatable lung volume. So this term or this way is probably not the best way because we should correlate it to the baby lung ratio or tidal volume. So the smaller the residual volume, the smaller the allowable tidal volume in these patients. And this brings us to the concept of strain in ventilator-induced lung injury. So the change in length in relation to the initial length, which means the tidal volume that we apply in relation to the volume at end expiration, which is FRC plus the PEEP volume. As FRC is reduced and the people we try to compensate partially for the reduced FRC. You have to be careful in severely reduced, in patients severely reduced FRC about what tidal volume size we're going to use. And this brings us back to this situation. So in the normal lung, where we have a normal FRC, allowable tidal volumes can be quite big without we having the risk that we overdistend these lungs. Whereas in the sick lung, the lung with a low FRC, there is a higher risk that even with small tidal volumes, we can overdistend the lung. So in this condition, we have a low strain condition. Here, you're at high risk for a high strain condition, which means high risk for inducing further injury. This has been taken account in the PALH recommendations about what you should do with tidal volumes. We say that this time, tidal volumes need to be adjusted according to disease severity. So it's not to body weight as an only term, it's disease severity. So we say 3 to 6 meters per kilogram for patients with poor respiratory system compliance, and closer to physiologic range 5 to 8 for patients better preserved respiratory system compliance. And the new upcoming recommendation that will probably come out this year, we stay more or less on the same recommendations. And this brings us to my approach to a patient. So my first ventilator settings. If I have a patient post-operative care with a normal lung, I assume that his compliance, the respiratory system compliance, is more or less normal. Let's say 0.8 to 0.9 ml per centimeters water per kilogram. So if I take according to recommendations now 6 to 8 ml per kilo, I will need about 7 to 10 centimeters of a driving pressure, distending pressure above PEEP. I add a low PEEP to start with, and I will end up with an inspiratory pressure about 12 to 15. As I use normal tidal volumes, normal respiratory rates will allow for normal minute ventilation and consequently normal CO2 washout. However, if I have a patient with hypoxic respiratory failure, infant respiratory distress syndrome, pediatric ARDS, in terms of mechanics, they're the same, congenital diaphragmatic hernia, I assume that they may have a reduced compliance, and this I assume according with the oxygenation deficit. So let's talk here about the reduced compliance by 60%. So about 4.4 to 0.5 ml per centimeters of water. So I know the residual aerable lung volume is small. So I start with smaller tidal, 4 to 5 ml per kilogram, and we'll observe what I need to achieve this tidal volume in terms of driving pressure, distending pressure, and you will end up with this kind of compliance around 10 to 13 centimeters of water, plus underlying PEEP of minimum PEEP of 5 centimeters. I will end up with inspiratory pressure around 15 to 18. So you see that you're in front of a patient that has already 25 centimeters of inspiratory pressure. Maybe you do something wrong in your settings, or he has a very, very poor compliance. As I use smaller tidal volumes, I will increase the respiratory rate to compensate for CO2 washout to have normal minute ventilation. And it's only then, and I think, to start about oxygenation, improvement, and PEEP. And I think this is a safe approach, starting first with what we do in distension to the lungs before we think about how we can improve oxygenation. Remember, oxygenation or hypoxemia is not killing the patient. And this brings us to the plateau pressure limitation. The recommendations are 28 centimeters of water, slightly higher if you have poor chest wall elastance, because this is compressing against the extension. So 29 to 33, the recommendations. To explain what we mean with this, what do airway pressures mean? So if I apply a plateau pressure of 25 centimeters, my transpulmonary distending pressure, the one that is creating the lung volume at end inspiration, will be 25 if my intrathoracic pressure is 0. So this is the condition of the paralyzed non-active patient. If my patient has a severe chest wall edema or abdominal distension, There's a counter pressure which will increase the intrathoracic pressure, let's say to 10 centimeters of water. My 25 centimeters I apply will end up therefore in a transpalmar pressure of 15, so 25 minus 10, of transpalmar pressure 15. So despite applying 25 centimeters of water, my lung volume at end inspiration will be much smaller than in this condition. So we have to keep this in mind. What we do outside does not tell us exactly what's happening in terms of transpalmar pressure inside. And this brings us to the concept of distending pressure, as I mentioned already before. So this study by Amato, taking back the data from several ARDS adult network trials, actually was showing then when the distending pressure, the pressure above PEEP, was more than 15 centimeters of water, there was a clear increase in mortality compared to predicted outcome of mortality. And if you can see here, if you take these ranges of distending pressures from about 8 to up to 33, you can see here that tidal volumes these patients saw with this kind of distending pressures are overlapping. So the tidal volumes do not give us a real good indication about what we should do in a patient. And distending pressure indirectly gives us a safety approach, because in the severely ill patient with poor respiratory system compliance, if I use a distending pressure of 15, my tidal volumes will be smaller automatically than in a patient with a good respiratory system compliance if I apply the same distending pressure. However, I do not say that you have to use 15 centimeters of water distending pressure. If you can keep below and still ventilate the patient, keep it below this magic number. This has been compared and confirmed in the lung-safe study in the adults, where they could show that the driving pressure in this range above 15 was actually associated with higher mortality. Plateau pressures above 30 associated with higher mortality, and peak and speed pressures above 35 associated with higher mortality. So, first part conclusion, optimal tidal volumes. The term volutrometer does not primarily refer to the concept of tidal volume, but to the ratio of tidal volume versus the residual functional lung volume. So the sicker, the smaller the lung, the smaller tidal volumes are allowed. And in this pressure limitation, as we use many of us pressure control ventilation, allow for automatic dynamic tidal volume adjustments by the ventilator, because the pressure effect will be depending on compliance. Tidal volume targeting, as it becomes more common again, certainly in the neonatal field, might be preferable in some patients, some populations, when you want to really assure the risk of hypoxemia or the risk of going into hypercapnia in these patients. But again, this would be a second step once you sorted out the appropriate tidal volume for this patient in his today's condition. So in any case, tidal volumes greater than physiologic tidal volumes, that are about 6 to 8 milliliters per kilo, in normal subjects should never be allowed. So what do we know about PEEP levels? PEEP levels, the recommendation, and I did not like them too much at this time. Moderately elevated PEEP levels 10 to 15 according to observed oxygenation and hemodynamic response. So you have to turn up somewhere your PEEP and see what the hemodynamic response and oxygen response is. Certainly want to avoid hemodynamic problems when you increase PEEP. And we said also at this time, as a compromise, PEEP levels greater than 15 might be needed for severe ARDS. Also, attention should be paid on meeting the plateau pressure. Because if you have 50 or 18 centimeters of water of PEEP and you add on top 15 centimeters of distending pressure, you will overdo allowed plateau pressures. So what does mean provide enough PEEP? It would provide enough PEEP means to recruit the recruitable alveoli, while at the same time not applying so much PEEP that healthy regions are unnecessarily over-distended. So if you have in this ARDS lung, we do incremental PEEPs, we may reduce intertidal alveolar collapse and opening because we're going to have an effect on the aerable and recruitable lung volume. So here we could recruit some lung volume. But there is a risk that in the normal aerated area with high PEEP, we're going to cause lung hyperinflation. And it's actually a fact that the ARDS network trial, who trialed 6 versus 12 meters per kilo, did not only look at tidal volumes, he had also a PEEP titration scheme in it. So according to the FiO2 needed, PEEP had to be dialed in, and you can see in very severe hypoxemia requiring high oxygen concentrations, very high PEEP levels were used. So we have to be a little bit careful to say it's only tidal volume that made the difference. It's highly likely that the PEEP titration scheme had effect on outcome as well. And this is somewhere confirmed by this meta-analysis by Briel, who looked into the time to death in hospital for higher and low PEEP levels stratified by prevalence of ARDS at baseline. And you can see here in patients with ARDS, higher PEEP levels were associated with better outcome than lower PEEP levels. Whereas in patients without ARDS, this association could not be shown. And what do we know from the pediatric field? We have no real randomized controlled trials or meta-analysis, high versus low PEEP. But I think we have a very important study from Robin Kemani's group in Los Angeles, where they did a multi-center retrospective analysis of patients with pediatric ARDS. And they were looking in these patients if they received a PEEP level above the recommended PF ratio concept of the adult ARDS trial, the one I showed you before, or whether this PEEP was below this recommendation. And you can see for all patients, when on protocols, the high PEEP group, which means at least as much PEEP as recommended by the ARDS network trial or above, was resulting clearly in a better, much better outcome than using too low PEEP levels. And this was the most marked for this, the moderate ARDS group. So we can say nowadays that keeping or using PEEP levels at the level or slightly above what the PF ratio scheme from the ARDS network trial was recommending seems to be an important protective ventilation strategy for pediatric ARDS and should be used as a first step in any unit. And this brings us to the question of recruitment and the question we should ask us in front of an ARDS patient: how is his lung functioning? Usually we have 3 components. We have diseased lung, non-recruitable, we have the diseased lung, recruitable, and we have some normal lung areas. So there is a risk as soon as I increase PEEP that I may over-distend some area, create dead space, with the risk of baro and volar traumatism. On the other hand, if my PEEP is too low, I have the risk of shunt, intrapulmonary shunt, zone of atelectasis, and atelector trauma. So this is the reason that we recommend to use recruitant approaches, which means with small tidal volume, least distending pressure as possible to achieve with the respirate and combination of tidal and respirate reasonable CO2 to titrate PEEP slowly up in front of a patient with severe hypoxemia, testing out if he can recruit or not, if there is improvement in oxygenation. So this means you increase in small delta pressure, small tidal, and slowly your PEEP by steps up and down again. You should observe when the patient is recruiting that at some level, maybe much higher only, that he starts to improve oxygenation without that you create more dead space, means without that you over-distend, and this can be sorted out usually by CO2 measures online. And make sure that you do not run hemodynamic compromise. This approach has been used here in adult patients with ARDS, looking at oxygenation, at dynamic compliance, shunt fraction, and the amount of non-aerated tissue. They slowly went up to a high level of PEEP, and then from here they come slowly down with the PEEP level, keeping the delta pressure the same. And you can see that when going up or when coming down, oxygenation was initially very high. At a certain point, it starts to drop again, so collapse is starting to happen. Shunt is coming back, as you can see here, and you can see that the CT non-aerated tissue percentage value is increasing. A good indicator where this actually happens is the compliance. So dynamic compliance going and improving when going up, sliding off because you're already standing here, and then when coming back, getting a very high increase of dynamic compliance before collapse starts to happen, where it starts to drop again. So looking at bedside during recruitment maneuver, small steps at dynamic compliance, oxygenation, and CO2 is a good mean to work this out. What do we know from recruitment maneuvers? Again, pediatric data is sparse. We have some meta-analysis from recruitment maneuvers for adults, and you can see that the studies showed in general a slight benefit with risk ratios between 0.8, 0.8, 0.8, and 1 here. So this one it showed no real benefit, but the other showed just a borderline or a real benefit. But the quality of evidence is relatively low, because most of the studies included other co-intervention at the same time. So it's really hard to conclude nowadays it's only the effect of recruitment that had an effect on outcome. However, Cosmetic study here, a really nice study that used this open lung approach concept, going up, going down to find the best place before oxygenation started to drop and compliance started to drop, showed much better outcome for patients submitted to this recruitment approach with an open lung approach compared to control that were not recruited at all. So PEEP levels, as said before, you can deal around with some numbers. Nowadays, we recommend to use, if you do not do formal recruitment maneuvers, to use the p-ARDS network PEEP FiO2 scheme, which is in fact some kind of indirect recruit effect. The more oxygen you need, the higher the PEEP. And recruit maneuvers can be attempted, but you have to be careful, do it slow and incremental and decrement PEEP steps. Do not know sustained inflation, do not use sustained inflation, because these are highly risky, because you do not know how high you have to go up and come down. So the question is now the combination. Again, tidal and PEEP combination bring us back on the strain. So we have to think about the tidal volume and the effect of PEEP in terms of creating inflatable lung volume for gas exchange above FRC. So again, this discussion, tidal volumes smaller if you have a sick lung with a low compliance, with a low FRC, with poor oxygenation, larger tidal volumes if you have a more normal lung, higher PEEP used if you need a lot of oxygenation according to PF ratio scheme from the p-ARDS network trials, lower PEEP used if you have better oxygenation according, again, the PEEP FiO2 ratio from the p-ARDS network. And if you take this concept of strain on the study from the adults, from Amato, where he was showing when you keep PEEP stable in patient, you increase your delta pressure above. The higher the delta pressure, the higher the risk for mortality. If they kept the plateau pressure stable and increased stepwise PEEP, so different groups with higher or smaller PEEPs, the higher the mortality when low PEEP were used. There was big descending pressures. The lower the mortality with high PEEP and lower descending pressure on top, independent of the plateau pressure, as it was here, independent of the PEEP pressure. And he worked then out, then if you increase your PEEP, so you compare patients with lower or higher PEEP, up top always the same limiting descending pressure of 15, there is no effect on outcome in any combination as you keep distending pressure stable. So this brings us back that distending pressure is an important parameter nowadays, and there are upcoming studies from the pediatric field, several of them now under submission and in publication, in preparing for publication, that show the same effects in the pediatric population. Brings us back to the lung-safe study. Driving pressure, the most important factor that has an influence or is associated with outcome in adult ARDS. So here, certainly for moderate to severe ARDS. PEEP has an effect in some populations, some groups, severity degrading. The plateau pressure has an effect in severe ARDS, whereas once more, the tidal volume shows no association to outcome at the end. So the best recommendation nowadays, what can we say? Protective ventilator strategies provide enough PEEP to recruit the recruitable alveoli. I think this is the important part, and you have to give your means at bedside to understand what's happening to this lung. Do I have an effect on oxygenation? I'm sure I do not have hemodynamic compromise. I am sure that I do not over-distend, and to recognize over-distension best is to do continuous CO2 monitoring, because it will respond to the increase of dead space that you create when you over-distend the lung. Avoid a PEEP tidal volume combination that unnecessarily over-distends the lung regions. So if you use very high PEEP, be very careful with tidal volumes on top. And again here, the distending pressure may help to give you some security on the tidal volume combination. Limit your inspiratory pressure, plateau pressure, to 28 to 30 centimeters of water. And limit your distending pressures. Go about in every situation, even normal or a sick lung, more than 50 centimeters of water. In the sick lung, 50 centimeters of water will result in smaller tidal volumes, and you may, in a very sick lung, allow for very small tidal volumes to 3 to 4 milliliters per kilogram if it's necessary. So the concepts of lung protection is polytrauma, avoiding polytrauma or overdistension, avoiding collapse, trying to limit the volumes in terms of tidal volumes, and trying to limit the distending pressures. Distending pressures, because you have a lower limit given by the PEEP, you have an upper limit given by the plateau pressure, and the safe range is in here with limiting distending pressures, and in result of this, tidal volumes will be limited within the acceptable volume range. So there's few other questions that come up nowadays, and they're still unknown. What about maintaining spontaneous breathing versus using neuromuscular blockade? And if you look at the data in the pediatric areas, we have no proven data at the moment that neuromuscular is reasonable. And the question is, does it improve outcome? We are waiting eagerly the study from the Martin Kneiber's group on neuromuscular blockade in children with ARDS. Based on the adult, there is some signs that there might be a benefit for specific conditions. Big questions about patient ventilator synchronization. We always say optimize patient ventilator synchronization will improve outcome, but in fact, so far we do not have real good data to confirm this hypothesis. Then about the level of support, including proportional assist, should improve outcome. We do not have data yet in the pediatric field. So what about maintaining spontaneous breathing? The problem is distribution of aeration in the lungs, so the question between VAQ mismatch. With spontaneous breathing, as we have a diaphragm that pulls down, and this pulls down because of the shape mainly on the dorsal part of the diaphragm, we will improve ventilation perfusion relationship in this distal area, those who are prone to collapse most. Whereas without spontaneous breathing, the air goes mainly in the ventral parts, the anterior parts, because there is no diaphragm activity, because we push the diaphragm only down on this side, which means worsening of VAQ. This is the concept of maintaining spontaneous breathing. I can see here, without spontaneous breathing, the same patient, when he starts to spontaneous breathe at same ventilator setting, how much better he recruits this area by his own respiratory efforts, by his active diaphragm. So on the other hand, the active patient has become now a problem, or we consider that we have to be careful, because we learned about patient self-inflicted lung injury in the patient in whom we assist his spontaneous breathing. Again, I come back to this schematic drawing. In the passive patient, a plateau pressure of 22, a PEEP of 8 will have a certain volume effect. So the transpulmonary plateau pressure in this paralyzed patient will be 22. The transpulmonary distending pressure will be 14. Whereas when the patient takes big respiratory efforts, he will create a negative interthoracic pressure, and this will lead with the same settings to a plateau pressure, transpulmonary plateau pressure is clearly above 22, and a transpulmonary distending pressure, which is clearly above 14. So that's one of the recommendations. Also, if you are in non-invasive ventilation, where p-ARDS is worsening, not to delay too long intubation and keep control on sedation and paralyzing these patients to avoid these big pressures, transpulmonary pressure swing in the spontaneous breathing patient. These big pressure swings, as measured here with the esophageal pressure and ventilator pressure, are the ones that we are fear of. So the swings in the transpulmonary pressure will have an effect on lung stress, causing the inflation of big volumes. And you observe in these patients, you set a certain pressure setting, he starts breathing, and all of a sudden his tidal volume is much bigger. Be careful with tidal volumes that you read above physiologic tidal volumes. So go certainly not about, do not allow for more than 12 milliliters per kilo in a sick patient with spontaneous efforts, because this may be not a good sign. The patient might inflict by himself further lung injury. And this again to explain the problem, the pressure support mode here, this patient, he takes PEEP, esophageal pressure by inspiration. So the difference that actually comes to the patient as a transpulmonary pressure is the combination of the assisted breath level and the effect or the force that the patient creates himself. So be careful, do not allow for vigorous spontaneous breathing, do not allow for large tidal volume in these patients, because you may further increase your lung injury. And this brings us, and I come to the end, the concept of the adult patient in severe p-ARDS with a PF ratio below 150. They use neuromuscular blockade for the first 48 hours. PEEP settings, relative higher coding oxygenation exchange according to PF ratio table, Tidal 6 to 8. I could show when using neurovascular blockade for the first 48 hours, instead of assisting ventilation, was allowing for improved survival. Just one last word about the concept of permissive hypoxemia. We tend to say, well, this patient is very sick, which might be permissive and allow for lower oxygenation, and just try to stand out the problem. However, we have to remind ourselves that in hypoxemia, there is a hypoxic respiratory drive. So the patient will increase his respiratory drive, and this will lead again to higher pressure swings if he's on spontaneous breathing. So you can see here in a low FiO2, so saturation target only of a permissive target of 85 to 90%, low oxygen, patient increases respiratory rate, increases his spontaneous invert and his PO1. So the patient does more work. This will lead again to the risk of self-inflicted lung injury. So permissive, be careful in a spontaneous breathing patient. So this means when we take the PEMVEC recommendation published by Martin Kneiber and a group from ESMID respiratory section, we have to think about disease severity in restrictive disease, mild, moderate, severe, the classical severity degrading for ARDS, to which point we might eventually use high-flow nasal cannula, poor data if it's not for some bronchiolitis patient at the moment, CPAP, to which level CPAP or non-invasive ventilation, be careful not to go higher and not to use it in severe patients. Should we target lower tidal volumes than the 6 ml per kilogram? I think yes, certainly in the severe ARDS patients, and this tidal volume will partially be dictated by our pressure, the driving pressure limitation. Target value seems to be about 14, 15 for the pediatric patient, like for the adult as a maximal value, not as a target value, sorry. Higher PEEP, we recommend nowadays to use as a first attempt the PEEP FiO2 ratio from the ARDS network trial. Consider lung recruitment to sorting out if there is still some recruitable lung tissue. If this is the case, this should allow you to reduce the FiO2, and the consequence, according the PF ratios, keep your PEEP in the second part. Where's the point of high frequency oscillation? Martin Kneiber talked about, and extracorporeal life support. Thank you very much for your attention.
Thank you, Dr. Peter. I think, as usual, it has been a wonderful blend of physiology and evidence, and trying to build up the case, the why particular recommendations are there. I think that makes it self-explanatory for everyone, and so it is a wonderful talk. And I think there are several lessons which come out of it, because what Peter showed, ARDS is a syndrome, so you can't treat with same numbers each and every lung. And what he told us, in case the container itself is so stiff, you obviously have to ventilate with lower tidal volumes rather than trying to injure the lung. But if the lung is a normal compliance, then you target higher tidal volumes. And you introduced us to the concept of strain rather than only relying on tidal volume or PEEP as a marker of potential volume trauma or lung injury. And then Peter also highlighted the concept of self-inflicted lung injury by the patient. So which means we don't have to be afraid of intubation if required, and intervene at the right time. And of course, it's all easy to say, but it's an art and one has to learn over time. So thank you for that wonderful illustration, Dr. Peter, once again. And if Dr. Rajiv and Sridhar allow, maybe we can take up the question addressed to Peter straight away. I think there's some in the question and answer box. I can see Peter has already addressed many of them by replying, but there may be some more which he could address verbally. Is it okay, Dr. Sridhar?
Yes, sir. Yeah.
Peter, this side breath, it's a very controversial thing about side breath. Side breath in the treatment of ARDS.
About?
The side breaths, you give lung recruitment strategies.
As I said, we cannot recommend side breaths because you do not know which pressure level is needed to recruit. And if you use side breaths, it's depending on your definition. Is it 30 centimeters for 30 seconds, 40 centimeters for 40 seconds, or whatever you see from the adult population? The risk is that if you go up to a certain level of psi during a certain time, you may cause severe overdistension, or you may not have an effect at all. If you cause severe overdistension, you run the risk of hemodynamic compromise and problems. So the only way we consider, and it's also the Polish group in the new recommendations, if you do recruitment, go by small steps, use relatively small tidal volumes. There may even be low recommendations. excuse me, reduce small delta pressures or distending pressures to avoid any risk that you run in over distension. So Cybres we cannot recommend, and in my opinion, I said this for many, many years, you should never use them.
Thank you, Dr. Peter.
Thank you. So there's a question by Dr. Subhasini, Peter, about airway pressure relief ventilation. Is there any role in pediatric ARDS, and could it worsen the patient-induced, self-induced lung injury as you were mentioning?
Well, there is no solid data on APRV in the pediatric field. We have no controlled trials, so at the moment we have no evidence of the benefit of it. And it's depending how you set your settings, APRV, but since you let drop the pressure from time to time, depends where the patient is in his respiratory phase, it may have also at this moment, we may receive a very large tidal volume, as might happen the other way around if you use side, for example. So we have no data at the moment to recommend, but we need urgently studies.
Thank you, thank you. And then there's a question about the role of transpulmonary pressure monitoring. What is the role of transpulmonary pressure monitoring?
Well, the optimal, we should measure transpulmonary pressure. There are two issues. If you use independent devices, the problem is that you have these esophageal manometers, which are classically the balloon manometers, you have not stable readings. So it's crucial to inflate your balloon to the 0.1 milliliter exactly, otherwise you get completely wrong measures. This has been shown by us, and actually it was a very nice publication on this by Christopher News a few years ago from Los Angeles. So we do not have the real good tools. A way around this, if you have a ventilator that has transpulmonary pressure monitoring, so esophageal pressure monitoring with a kind of bicore device behind, that inflates at each measurement exactly balloon to the same volume, then you may get relatively good measures. But this is only feasible with fully integrated devices and not the classical way we would do it by side insuflating with a syringe. So at the moment we are stuck there, and the smaller the child is, the problem comes then much more. Do I add to the faster feeding tube another one? But it's a problem, and a big request from us to the industry is, and I take the chance of opportunity to mention this, when you have for the Navasons, where you have actually feeding tube and electrodes on one side, we would highly likely to have there also a reliable esophageal pressure measurement. But for the moment, for technical reasons, they cannot manage it in this small size.
Thank you, Peter. And another question by Dr. Gayatri: is there any role of diuretics in ARDS?
I think the data from the adults, again, based on data from adults, there's a role of diuretics. There's certainly a role to not fluid overload patients. So there's a clear association between restricting fluid and outcome in adult ARDS, independent on the ventilator settings they use. So it's a very strong signal there. Again, in pediatrics, we do not have real good studies about this. So I think my role is in an intubated patient, you have a reduced insensible loss of fluid because you do not evaporate. We do humidificate the system. So reduce your basic income in an intubation patient already by 20 to 40% of normal intake. And then you don't run into the problem that you really need diuretics. But in the early phase, in the inflammatory edema phase, it might help a little bit.
Thank you, Peter. And there's some question, I think they are going to be addressed in the subsequent talks about surfactant and all. So thank you again.